Good evening, dear friends of modern medicine across India. Hearty welcome to IMA College of General Practitioners, Indian Medical Association, Kerala State. Friends, empowering every doctor in their everyday medical practice is essential, and especially for modern medicine, because the science is getting updated day by day. And the patient in front of you is the biggest teacher. We all know. But we need to get scientific update. And we need to review ourselves whether we update regularly. Indian Medical Association Kerala State is bringing its Indian Medical Association's oldest academic wing, the College of General Practitioners, in front of you. The College of General Practitioners is really glad to present you on every Thursday with the same Zoom ID, Zoom link, and password the essentials of modern medicine for every day, for every general practitioners. Friends, we are extremely sorry for the initial glitches. Because of some technical trouble in our main studio. So let me offer a grand and a glad welcome to each one of you. And let me invite, today we have a topic, this is red flags in pediatrics, presented by a great faculty of, Indian Medical Association as well as Indian Academy of Pediatrics, Professor Dr. Sheeja Sugunan. Now, I welcome her too. And before going to the main program, let me welcome Dr. Biju Nelson, the Secretary of IMA Kerala CGP, to introduce the faculty formally. Over to you, Dr. Biju Nelson.
Good evening, everyone. It's my privilege to introduce our esteemed speaker, Dr. Sheeja Sugunan, a distinguished pediatrician and academician from Trivandrum Medical College. She's a professor as well as a very good pediatric intensivist, working as professor in Trivandrum Medical College. She has experience in pediatric clinical care, teaching, and research, and has made significant contributions to child health and medical education. She had actively involved in academic research and notable publications in pediatric infectious diseases and critical care. She's a faculty of IMA's almost all organizations, subcommittees like IMA, ALS, IMA, ICP, course on pediatric infectious disease, IAP WAC, that means course on immunization. But also involved in research. She has edited Immunization Application and Guidelines, 2nd edition. She also, in her name, Minivac Immunization Ready Reckoner, and she has already publications in UG and PG textbooks, pediatrics in national and international level. She has held the post of President IAP Intensivist Care Chapter 2021-22, and she's also a member of State Death Audit Committee, a member of State Medical Board, and reviewer of State Vaccine Policy. We are honored to have her with us today to share her expertise on the topic. On behalf of IMA CGP, I extend my warm welcome to Professor Dr. Sheeja Sugunan and invite her to deliver her presentation.
Over to you, Professor Dr. Sheeja Sugunan, and hearty welcome once again. Friends, let's enjoy and enrich ourselves in identification of red flags in pediatrics, which is very crucial. Over to you.
Thank you, sir. Good evening, everyone. First of all, I thank the members of the IMA GCP General Practitioners, IMA College of General Practitioners for giving me this opportunity. I thank all the office bearers, Dr. M.N. Menon, Dr. Prasanth C V, Dr. Roya Chandran, and Dr. Biju Nelson for this wonderful opportunity. So coming straight to my topic. Is it visible?
Yes, yes.
Okay. Okay, so coming to the topic, that is red flags in pediatrics. So I think all of us would have encountered children who are sick. Sometimes we know they are sick, and sometimes we find it difficult to identify they are sick. So I'll just share with you three scenarios that we had encountered in the recent past. A 6-year-old child presented with seizures to a local hospital. And because it was morning time, 6 a.m., no pediatrician was available. So immediately the duty doctor arranged a ambulance and referred the child. The travel time from the referring hospital was close to 2.5 hours. By the time we received the child was still having active seizures. He was having hypoxia and hypotension. He was immediately intubated, stabilized, but post 3 hours, the child's pupils were dilated and fixed. We had another child, an 8-year-old, presented with abdominal pain and vomiting. And immediately, the child had again went to a local hospital. The saturation was 89%. Vitals were otherwise okay. They started oxygen mask. The saturation improved to 95%. Again, a 108 ambulance was arranged and the child was referred. This time, the travel time was around 45 minutes, but we received the child in cardiac arrest. We could revive the child, but this 8-year-old normal, healthy child finally went back home completely crippled. Then we had another child waiting in the OPD, had come to the OPD, a 4-month-old with fever for 2 days duration. And the child was, initially the child was given some medications and sent back home. The same day night, the child was brought back gasping. So 3 different situations, 3 different outcomes. So could we have done something differently? Where is the missing link? So what we really plan to cover in the next half an hour or so would be how to, in fact, recognize a sick child. Once you've recognized somebody sick, how do you do a systematic assessment? And then how do you identify a problem and intervene appropriately? Now, we all know that many of us have very busy OPDs. And we all need to know that in 2019, the central government has brought out a rule which basically tells that anyone who's having a clinic running should have an OP assistant outside to see for the patients who are waiting outside while you're taking care of a patient inside. So now the question is, if you are, can your OP assistant, it may be anyone, it may be, say, a nursing assistant, it may be a qualified nurse, it may be someone you know, just standing there to help you out. Can he identify, can he pick up a sick child? So how can you pick up? So this may apply to a nursing student, this may apply to a medical student. How do you skip? So the basic thing is that just look at the child, but look at it in a proper way. Look how the appearance is. If the patient, like the baby, the next second baby, very interactive, playing with the mother, he can definitely wait in the queue. You need to see him only when it's needed. But if you have some obvious breathing difficulties or obviously the color is abnormal, then definitely you need to see the child early. And when we say appearance, it's not only the interactiveness we are bothered about if the patient is crying. Any baby can cry, right? It may be because he's not liking you, he's not liking the place, he's feeling hungry, but he may also be crying because he's got something severe. He may be having an acute meningitis. The only way a baby can convey that he's having a very bad headache is just inconsolable cry. It may be a surgical abdomen. The only symptom the baby shows is an inconsolable cry. So always remember, inconsolable cry is a danger sign. The moment you see a baby crying, we always should say, ask the mother to please feed and allow the baby to be calm. If the mother says that, no, my baby is not just crying incessantly, then that is a danger sign and we need to examine the child first. Similarly, a baby is sleeping on the shoulder. You may think, yes, baby is sleeping. What is wrong with it? That is good, right? But how do you know this baby is not drowsy? How do you know that this baby is not an unconscious baby lying on the shoulder? So remember, whenever the baby sleeps also, there is a tone. If you really look carefully, you would realize that the hands are kept partially flexed. The legs are also partially flexed. There is a tone. But if you find that the baby on the shoulder looks completely flabby, like a rag doll, or you can always go and ask the mother, the baby is really sleeping, no? Or is it that the baby is sleeping too much today? And if they say it's always been sleeping, again, that is a danger sign and you need to see the baby immediately. And as we already said, breathing and color, you can obviously see the baby is obviously appearing pale, cyanosed or mottled, need to be seen immediately. So here, how much time are you going to take to identify a sick child? 5 seconds. You're just looking. It's a doorway assessment. You're not touching the child, but you're looking at the appearance, breathing, as well as color, and just trying to identify if the patient is sick or not. Now the patient has come inside or patient has come to you and the complaint is the fever for 2 days. Now, when the mother says there's fever for 2 days, it can be simple viral fever, right? But it can also be a sepsis or the patient may be in septic shock. Just by asking a history, how do you know that this baby does not have a serious illness like a sepsis or septic shock? You can simply ask some simple questions. Ask how is the baby in between fever. Every baby, when the fever is there, just like us, they will also be lethargic, they'll be lying down. But they don't have any anticipations like that. They don't think and say, I'm having a headache, I'm feeling tired. No. The baby, the moment the paracetamol you give, the fever comes down, he'll be running around. Next fever, he'll again come back and lie down. So ask for the interfebrile period activity. If the mother says interfebrile period is very active and playful, don't worry. Most probably you're dealing with a viral fever. But if the mother says there's no interfebrile activity, baby continues to be lethargic, then that is a danger sign. Then you can always ask for decrease intake. Just like us during fever, they also take less food, right? So how can that be a danger sign? Always remember, a baby who's feeding at breast, however sick he is, he will continue to feed. It's just like having water. When you're thirsty, you would definitely drink the same way. But if a baby who was always taking a breastfeed stops taking a breastfeed, that is a danger sign. Yes, sometimes it may be a small sign, maybe it may be a nasal block because of which the baby is not able to feed. But in most of the situations, we always say, think about the worst situation, don't trivialize it. So a baby who's not sucking at breast is an emergency, needs to be seen by a doctor. And how do you know the patient is not in shock? You don't have to check his BP, you don't have to check his pulse, just ask, how's the urine output? If the mother says that he's passing urine every 6 to 8 hours and just normal color, you can be rest assured that at least he doesn't have a hemodynamic compromise. And of course, you can feel for the cold hands and feet because children, warm septic shock is rare. They usually come to you with a cold septic shock. And of course, breathing difficulty, you can see or you can act, or you can ask also. So just look at that. Just simple 5 questions. You are able to identify if there's something greatly wrong with the cardiovascular, the nervous system, or the respiratory system. So now the patient has come inside and you want to examine. So the first examination is primary assessment. That means you will go in a systematic way, looking at the airway. Airway, basically, you're looking, are there any secretions? Is there a noisy breathing? Am I hearing a stridor? Breathing, we all know we would be looking at the work of breathing, whether we are getting auscultating for any added sounds. We're looking for saturations also. Then, of course, the circulation, where you're basically looking at how the extremities feel, how is the pulse volume, is there a tachycardia, and the blood pressure. And in disability, what do we mean by disability? Are we looking at the patient disabled or not? No. We are looking for the consciousness. You may not have the time to do the whole GCS score. Just do an AVPU score. What is AVPU score? A means baby is alert. V means the baby is voice responsive. P means the patient is pain responsive, and U means is unresponsive. So just write AVPU and circle what you feel the baby's current sensorium is. Then, as I already said, look for the tone. Look for the pupils if they're equal and reacting, and don't forget to look for the blood sugar. Extremely important, because children who are sick, they tend to go for hypoglycemia quite early, and any condition the baby is presenting to you, hypoglycemia can worsen. And last but not the least, always expose and see. Are you seeing any bite marks? Are you seeing any hemorrhages? Are you seeing any petechiae? Is the patient febrile? So exposure is also important. So you may ask, I have a very busy OPD. I'm seeing 300, 400 patients. How do you exactly expect me to do all this? But do you know what is the time given to you for doing a primary assessment? Just 60 seconds. That is 1 minute. It's only that we are doing the same thing that we routinely do whenever we are seeing a patient. But only thing is that we would be going in a systematic way. That means when you're looking at the patient, simultaneously, you're looking at how is the airway, breathing, circulation, disability, and exposure. And at the end of this primary assessment, we don't want a diagnosis. We don't want ourselves to say patient is having a right lower lobe pneumonia or patient is having a bacterial meningitis or encephalitis. No, we want to identify whether there is a major physiological problem. So what physiological problem? We need to identify if the patient is in respiratory distress or respiratory failure. If the patient is in shock, how severe is the shock? Is it hypotensive or compensated? Is the patient has a cortical or a brainstem dysfunction? If you're able to, and also try to see the cause. For example, a patient with respiratory distress, see what caused the respiratory distress. Patient in shock, try to identify the cause also. Now, why is it important to identify the physiological status? Remember, there may be 101 reasons why a patient comes to your OPD. It may be trauma, it may be infection, poisoning, metabolic causes, cardiac, anything. But for a baby to die, for a patient to develop a cardiac arrest, there has to be a physiological derangement happening before that. Unlike in the adults, where you can have an unexplained MI or a arrhythmia setting in, these are situations which are extremely rare in children. Most of the time in children, in babies, you always have a physiological derangement that progresses to cardiac arrest. And that is also the reason that most of the situations we will be able to prevent a cardiac arrest if we identify a physiological derangement and intervene. So once you have done the primary assessment, then there is the secondary assessment. Secondary assessment has two components. The first component is get a focused history. That is a very brief but focused history. You're looking for the signs and symptoms, asking for allergy, asking if the patient is on medications, a past medical history. When did the baby have the last meal? Because in case you want to put the intubate, you want to know whether there is a risk for aspiration. And of course, the events leading on to that is what we call it as a sample history. And then you do a focused examination. Focused examination means you will do a head-to-toe examination, specifically concentrating on areas that you did not concentrate in the primary assessment. So you may be a small baby, you will start from the anterior fontanelle tension, you will look for the signs of dehydration, you will come to the chest and abdomen. Abdomen, especially, you will look for the hepatosplenomegaly. Coming down, you will look at the limbs, and then you will also look at the spine. So, and the system that you identified in the primary assessment, you will look at a little more detail. And after that, you send investigations and finally reach a diagnosis. Now, let us see a prototype case. This is a 3-month-old child presenting with fever, URI, and breathing difficulty. On examination, child is tachypneic and tachycardic with saturation of 92% with bilateral crepitations and V's. A 3-month-old child, URI, fever, breathing difficulty. What diagnosis does come to our mind? Most of us would definitely think about bronchiolitis, right? A URI and a breathing difficulty with wheeze and creps. Now let us see, and you would offer probably an oxygen by prongs, that because the saturation is 92. You always want a saturation between 94 to 98 as far as a child who is sick is considered. So now let us do a systematic assessment and see what we are missing or how this thing changes. Now, when I look at this child, I realize that there are secretions, so I give a suction. When I look at the breathing, I realize that air entry are equal, that capitation saturation is 92, so naturally an oxygen support. When I come to the circulation, I realize that extremities are cold, he's tachycardic, his CFT is 3 seconds, the baby's BP is only 60 systolic and the heart rate is 160. That means I'm not just dealing with a respiratory problem, I also have a cardiovascular problem. So immediately I start a normal saline bolus, 20 ml per kg. When I come to disability, I realize that the patient is pain responsive only. The sugars are only 28. So the patient is hypoglycemic. So immediately a D10 push is given. And when you expose and see the temperature, it is 101. So immediately a paracetamol suppository is also given. So just look at that. You've done a systematic examination. You found out so many problems in this baby and so many interventions. And now you move on. After that, naturally, you move on to the secondary assessment. Focus history did not reveal anything much. But when you go for a focus examination, that is head to toe, and you looked at the abdomen, you picked up a hepatomegaly, 5 centimeter. So what are you now dealing with? You have a patient who's in respiratory distress, who's patient in hypotensive shock. On top of that, patient has hypoglycemia, having a secondary cortical dysfunction, and now you have picked up a hepatomegaly. So naturally, now you're thinking in terms of maybe I'm dealing with a cardiac cause. So immediately you send your investigation, which also includes a chest X-ray, and you pick up a huge heart. So what are you dealing with now? So what we initially thought as bronchiolitis has now turned out to be a cardiogenic shock. So immediately the fluid bolus is stopped. The maintenance is started because the patient is hypoglycemic. Oxygen is provided under pressure. That means either a NIV or a BiPAP or a CPAP would do very well, because any LV failure, it is always better to give oxygen under pressure because the pulmonary edema would be resolved. And of course, inotrop was started. So what did we learn from this child? So just imagine, initially when you started your primary assessment, you had in fact missed that there was a cardiac problem. You were thinking again in terms of a respiratory problem, along with that a shock. But within 3 minutes, you have reached the secondary examination and you have picked up a hepatomegaly and you have stopped the fluid. So you haven't harmed the child. This is exactly what is meant. So always do a systematic assessment. 99% of time, it is unlikely that you would miss a grave illness in a sick child. So it's very important that we do in a proper systematic. So what did we learn till now? We learned that the moment a patient comes to the OPD, just look at the patient, appearance, breathing, and color, and form an initial impression is the patient is sick or not. And once the baby is in front of you, please do a primary assessment, that is appearance, breathing, A, B, C, D, E, and identify the physiological status and provide appropriate interventions whenever you identify a problem. Do a proper secondary assessment and then send relevant investigations and finally reach a diagnosis. So now coming to the second case, 2-year-old child presenting with breathlessness. Now what's the question? The question is, what do you think? Is this child having a respiratory distress or respiratory failure? Now, why is it important to know if the patient is having a distress or failure? The problem is, if the patient is having a respiratory distress, then the journey from distress to a respiratory failure is a pretty long one. But the journey from respiratory failure to cardiac arrest is only minutes away. So whenever a patient comes with a breathing problem, we need to identify if the patient is in distress or failure. Now, what do you mean by respiratory failure? Respiratory failure doesn't mean that the patient is not breathing. Yes, when the patient is not breathing, it is respiratory failure. But when the patient is hypoxic or hypercarbic, also the patient is in respiratory failure. So when the patient saturation is less than 90%, it is hypoxic respiratory failure. That does not necessarily mean that you have to put the patient, intubate or something. It only means that you have to provide him with an oxygen support. Similarly, how do you identify a hypercarbic respiratory failure? That is more ominous. Now, what do you mean by hypercarbic respiratory failure? Remember, carbon dioxide is 20 times more diffusible than oxygen. So when will the carbon dioxide go up? The child that we saw just now, breathing very fast with so much of distress, it's unlikely that he has a hypercarbic respiratory failure. Hypercarbic respiratory failure means the patient is hypoventilating. He's breathing less. Or there should be a situation where you have a single lung ventilation, say a pneumothorax or a collapse, because of which the aeration is not happening to a significant portion of your lung, and then the carbon dioxide is going up. So hypercarbic respiratory failure can normally be picked up only by sending a blood gas. But always remember, any child with respiratory distress, he should be ideally agitated or he should be anxious. But instead of that, if the patient is drowsy usually indicates patient is having a carbon dioxide narcosis and probably he's in hypercarbic respiratory failure. Similarly, a flash capillary refill. And also remember, when a patient comes with respiratory distress, say initially the heart respiratory rate is 60 per minute. After some time, it becomes 50 per minute. So you will say, oh, my patient is improving. He had come with 60 and now the respiratory rate has come to 50. But remember, if the patient is really improving, an improvement in respiratory rate will always be associated with an improvement in heart rate. If you find that the respiratory rate is falling and the heart rate is increasing, again, that may be an indicator patient is going for respiratory failure, he's hypoventilating, and he may go in for a cardiac arrest anytime. So please remember, it is not only hypoxia that means respiratory failure, hypercarbia is also respiratory failure, and the classical clinical sign is drowsiness. A drowsy child with a respiratory problem, please think of hypercarbic respiratory failure, which definitely requires a respiratory support and not an oxygen support. And once you have identified the severity of the respiratory problem, then we should be able to say, why is the patient having a respiratory problem? That is, whether it is an upper airway obstruction, a lower airway obstruction, a lung parenchymal disease, or is it a disordered control of breathing? Now, how do you identify all of this? Sometimes, just by looking at the patient, you may be able to identify what the problem is. How do you identify? You can look at the site of retraction. Now, if you find this, what are you seeing here? You're finding a baby who has a distress, but where are the retractions? The retractions are in the suprasternal notch and sternal retractions. Suprasternal and sternal retractions basically means that you are having a major airway obstruction, so usually an upper airway. Remember, babies are obligate nasal nose breathers. So if you have a complete nasal block also can, but commonly this may indicate a laryngomalacia. This may indicate a foreign body in the upper part, it may indicate a croup. Whatever it is, usually indicates upper airway obstruction. Now, what about this baby? What are you finding here? Again, another child who is having respiratory distress, but this time it is subcostal retraction. Look carefully. What are you seeing here? You're seeing here that the inspiration is short and the expiration is prolonged. And if you also look carefully, you can also make out that this baby is using her shoulders to expire. Every expiration is associated with forward movement of the shoulders, again showing you that she is finding expiration more difficult than inspiration. This is a classical sign of a lower airway obstruction or asthma. Now, what about babies who have intercostal retractions, especially when you have lower chest in drawing? When the baby is breathing, you can see that lower chest is going inside. Why is it happening? Because your lung compliance has gone down. Why is the lung compliance gone down? Probably you are having a pneumonia. And when you have a pneumonia, the lung compliance goes and the severe pneumonia is associated with lower chest in drawing. So this indicates that the baby is having a lung parenchymal disease. Upper airway obstruction, we classically have stridor. Stridor means this is the sound that you get in stridor. Whereas when you have a pneumonia, the sound, airway sound that you get is that's a grunt. Now, what does grunt mean? Grunt means a parenchymal disease. Yes, sometimes you may have a baby grunting because of high fever, but we always say rule out pneumonia in a grunting child because grunt is a symptom of pneumonia, and grunting happens because the baby tries to expire against a partially closed glottis in an attempt to maintain the functional residual capacity or in an attempt to keep the alveoli open. So grunting is a sign of pneumonia. So which oxygen delivery device would you use? If the patient is coming to you sick, the first device that we commonly use is a non-rebreathing mask. What is the advantage? Because it gives you the maximum FiO2. But remember, you have to keep at least 10 liters per minute. The bag has to be completely inflated, only then it is delivering appropriately. Oxygen mask will give you an FiO2 close to 40 to 50%. You have to keep minimum 5 liters per minute so that carbon dioxide rebreathing is not happening. When it comes to nasal prongs, infants, we keep 2 liters per minute. Child, you can keep 4 liters per minute. An adult, we all know, can be kept even 6 liters per minute. The difference is because that is the only air that a baby can humidify. So a newborn will keep 0.5 to 1 liter, an infant up to 2 liters, because only that much can be humidified. And if the patient is not breathing, is hypoventilating, none of these oxygen delivery devices are going to work. You have to give an artificial ventilation by using a bag and mask ventilation. And as I already said, your target is never 100%. You're giving an added oxygen. Your saturation should be less than 98. Hyperoxia is harmful. So we usually want it around 94 to 98. Recent evidence says that you can go to 89 to 92, but commonly we target 94 to 98. So now coming to this child, 1-year-old child presenting with fever, URI, breathlessness. What are you seeing? So I hope you could hear the sound. That is the stridor. So when you have a patient with stridor, remember there can be multiple causes of stridor. If the mother says that it is present since birth or present since 1 week or 2 weeks after birth, it means probably this baby is having a congenital laryngeal stridor, which gets worsened whenever the baby has a URI, which is not a great problem. If the patient says that the baby was perfectly okay and suddenly developed this stridor, think about foreign body. Acute stridor, usually foreign body. Now, if the baby is telling that the baby had a URA cough, initially it was a Brazil cough, and from today morning is having stridor, that is a classical history of laryngotracheobronchitis or croup. And that is something that we commonly encounter when you're taking an emergency room. So when the patient is presenting to you with a laryngotracheobronchitis, that means a patient is having respiratory distress, having suprasternal sternal retractions, he has a stridor, then what will you do? So if the patient is hypoxic, please provide him with oxygen. But always remember, hypoxia is a late sign as far as upper airway obstruction is considered, because your lungs are perfectly normal. Even a little bit of air going in will maintain the saturation. And also remember, stridor in a crying child is not a danger sign. Stridor in a calm child is a danger sign. Because when the stridor is happening in a calm child, it basically means that your airway is so narrow that it is producing a stridor even when there is no increased effort at breathing. So you can give oxygen if the patient is hypoxic in the most unthreatening manner. The baby cries, the stridor increase. So keep the baby calm, keep the baby on the mother's lap. You can even give a free flow oxygen. Don't make the baby cry. And the drug of choice is definitely dexamethasone. You can give it in any way you want, oral, IV, or IM. The dose is usually 0.6 mg per kg. But if the patient is severely dyspneic, then you can definitely give adrenaline nebulization. Now, a word about adrenaline nebulization. That is, normally we will take 5 ampules of adrenaline and give it as a nebulization. That is 5 ml undiluted adrenaline nebulization. But in case the patient's stridor is persisting and you want to repeat adrenaline nebulization, then the dose is 0.5 ml per kg to a maximum of 5 ml. So because adrenaline gives you a fast relief, but there are certain things that you need to remember. The duration of action of adrenaline nebulization is 60 to 90 minutes. So if you have given an adrenaline nebulization, you have to observe the child for 2 hours to see that whether the stridor is coming back or not, and only then discharge the child. When you have given, if patient is not responding, you can repeat at 20 to 30 minutes interval. Any child who has a stridor persisting, even after 4 hours of a steroid, that is dexamethasone, requires admission, because dexamethasone will take around 4 hours to act. Steroids take time to act. By that time, the distress should come down. If at that time also the distress is persisting, that means the child requires admission. Now, coming to the next case, 2-year-old child playing with toys suddenly develops coughing and breathing difficulty. So what are we dealing with? Sudden onset of cough and breathing difficulty, most probably a foreign body. What do you want to do? Do a blind sweep and see if you can retrieve the toy. Do a Heimlich maneuver. Arrange for transport to hospital. Take an X-ray and decide, or reassure and wait. The first answer is, if the baby is coughing, just allow him to cough. This is applicable to baby, adult, anyone. Because the coughing is the best method of bringing out a foreign body. That is your body's method of bringing it out. And someone who's still coughing means that the upper airway is not completely obstructed. So allow to cough. And after coughing or during coughing, the baby becomes cyanosed, there is no sound coming out, there is absent air entry, definitely that is the time for intervention. If it's a small infant, you go for 5 back slaps followed by 5 chest thrusts. You continue this process till the foreign body comes out or the baby becomes unconscious. If the baby becomes unconscious, you start your CPR. But during CPR, every time you will give the ambu, you will also look at the mouth to see if the foreign body is there. How does CPR help? Either during the CPR, when you're doing the chest compression, it will bring out the foreign body, or when you're doing the bag and mask, it will shift the foreign body to one of the bronchus. Even then, the baby would survive. Even with a single lung, you can survive and can be referred to another hospital where a definitive therapy can be done. A bigger child, definitely Heimlich maneuver can be done. Now, what happened to our child? Our child coughed for some time, and after that, the coughing stopped, but the patient was tachypneic, had severe respiratory distress with unequal air entry. At this point, should you like to try a Heimlich? The patient is having respiratory distress. The answer is no. Once the foreign body has moved on to one of the bronchus, your Heimlich is not going to bring it out. The Heimlich will bring it out, or the back slaps will bring it out only when the foreign body is in the major airway or is in the trachea. So no active interventions, no maneuvers. Just put a NRM, non-rebreathing mask, which gives you the maximum oxygen, and refer it to another hospital where a definitive intervention can be done. Now, coming to the next case. So now from the respiratory, we are moving to something else. A 4-year-old child brought with complaints of fever of 4 days duration. On examination, the child is lethargic, he's febrile, extremities are warm, pulses are well felt. His heart pulse rate is 166, respiratory rate 40 per minute, BP is 86/40. The question is, are there any danger signs in this child? Look again, there are danger signs. What are the danger signs? Baby is lethargic. Lethargic always is a danger sign, which basically means that probably your cerebral perfusion is coming down. Look again, he's tachycardic, which is disproportionate to the degree of temperature that the patient is having. His BP for the age, 86 BP is okay, 70 plus age into 2. That means he is not hypotensive. But look at the diastole. The diastole is less than 50% of the systole. That means you are basically dealing with a wide pulse pressure, septic shock, probably in the compensated state. That is not in the hypotensive state. So this is a baby who is not only having fever, but is also having evidence of septic shock in compensated septic shock. Now, the patient BP has not fallen. The child is still no hypoxia. Patient is lethargic, but patient is still alert. Is there a need to stabilize? Can we refer the child immediately? Normally, what do we say? The moment you see a patient in shock, immediately start oxygen, because whatever blood is going to the tissues, let it carry more oxygen with it. Always check for hypoglycemia. If it is there, correct it. And along with the bolus of D10, that is 5 ml per kg, after that, please start the maintenance. The mistake that many times happens is you give a bolus and then you refer. But by the time the child comes to the next facility, he's again in hypoglycemia. Remember, every time any patient goes into hypoglycemia, especially a baby, a cell somewhere is dying, which will not come back when you give that bolus push. Some neurological damage is happening, which may later manifest as a seizure or an intellectual abnormality. So always prevent hypoglycemia. If you encounter a hypoglycemia, ensure the baby doesn't go for a repeat hypoglycemia. It is important. If it's a septic shock and the travel time is more than 1 hour, then always better to give antibiotic, because every hour delay in giving an antibiotic in septic shock increases the mortality by 7.6%. Now, but the question was, this baby was not in hypotensive shock. And I am working in a peripheral hospital with limited facility. Do I really need to do all this? Can I just refer the child without a fluid bolus? So the answer is, when the patient presents to you in a hypotensive shock, that is, the patient's BP is maintained, but the tachycardia is there. And this time, the heart is working extra and all your organs are getting perfused. Now, if you refer this child at this point, what will happen? The capillary leak will continue. The blood flow will come down, and this will damage the capillary endothelium, which will act as a nidus for thrombus formation. Microthrombi will form, and blood supply to many of your vital organs would slowly come down, and the patient may reach alive your next hospital, but ultimately may succumb to multi-organ dysfunction. So it's extremely important to know that if you encounter a patient with hypotensive shock or with compensated shock, please start the fluid bolus immediately and then refer. You don't want a deterioration there. Every hour delay in correction of shock increases mortality twofold. Now, if you're working in a peripheral hospital and the patient is in compensated shock, you don't have to start any boluses. Just start the maintenance and refer. When we say maintenance, yes, there is a formula, 4-2-1 rule and all. Don't remember the 4-2-1 rule also. Just start 3 to 4 ml per kg per hour of fluid and refer. You just don't want the patient to go into hypotension on the way. Why do they say like this? Because when you're dealing a patient in a compensated shock, there's no imminent risk of death, but there may be sometimes harm, like for the baby may be having a CCF, baby may be having an anemia, a baby may be with severe malnutrition, where large volume boluses may be harmful, and this baby is in compensated shock. That is why we say just start a maintenance and refer. But in case you are a pediatrician and you know you're dealing with a septic shock and it's in a compensated state, you can definitely give 10 to 20 ml per kg per hour and then refer. Now, what about if the patient is in hypotension? If it's in hypotension, it's always 10 to 20 ml per kg over 20 to 30 minutes, maximum of 40 ml per kg in the peripheral setup. You can either use a normal saline or you can use a ringer lactate. In a diarrhea, you always prefer ringer lactate, because in diarrhea, you're using bicarbonate, and the lactate in ringer lactate serves as a bicarbonate supplier. Whereas if it is a patient you're suspecting a meningitis or a raised ICP situation, normal saline would be better, because that would keep the sodium on the higher side. So either way, you can use whichever you want. If it's a hypotensive patient and you're referring, it's always better after the fluid bolus, you also start inotrope and refer, so that the patient does not collapse on the way. Compensated shock, you can refer with the maintenance fluid. So now coming to the next case, 6-year-old child brought, this is our first child that we had discussed. Patient coming in early in the morning when the pediatrician is not available and is coming with active seizures and is referred. So now we said that we had received the patient with active seizures, pulse rate, tachycardia, hypotensive. hypoxic and hypoglycemic. Immediately the patient was intubated, resuscitated, anti-epileptic drugs were started, and 6 hours post receival, child saturation was 98%, his BP was maintained, his urine output was good, but his pupils were dilated and fixed. When you mobilize the child for an emergency CT, this is what you see, that is gross cerebral edema. That means the patient has gone for a brain death. So what has really happened, or how differently we could have managed this particular case? So always remember that whenever a patient comes in with seizure, every hour, every minute delay in controlling a seizure beyond 5 minutes increases the chance of it lasting for more than half an hour by 6%. So controlling a seizure in a timely manner is extremely important. And also remember, when a patient is presenting to you with a seizure, if we are going to give anticonvulsant, especially a benzodiazepine earlier, the action will be better. If you delay administration of anticonvulsant, the same anticonvulsant may not be effective because there is something called receptor trafficking. As is, the longer the seizure lasts, there is excitotoxicity, there is internalization of the GABA receptors, because of which your benzodiazepines may not be acting well. So any seizure that lasts for more than 5 minutes, please try to manage the seizure, because longer the seizure lasts, there will be excitotoxicity, and as your brain cells are continuously being excited and the energy is being utilized, there is a chance of it going for hypoglycemia. Hypoglycemia will also add on insult to the already injured brain. Along with that, you've developed a hypotension. Again, some brain cells are going to die because of hypotension, and hypoxia is going to again kill. Just imagine, the patient was having seizure, a neurological problem. There have been so many other things added to the neurological insult, all contributed to the neurological insult, all contributed to cytotoxic edema, all contributed to the ultimate brain edema. So how we could have referred the child? So always remember, a patient coming in seizure, if there are secretion, suction, turn to side. Any seizure lasting for more than 5 minutes, start oxygen. Always check glucose. If glucose is less than 60, give D10. We don't give D25 as we do in an adult, because your babies have such delicate veins, they cannot tolerate such hypertonic fluids. So give D10, 5 ml per kg, and also give the first line anti-epileptic, which may be lorazepam, midazolam, or diazepam, whichever is available in your place. If you have an intravenous line, you can give lorazepam or diazepam slow IV. If you don't have an IV line, you can give midazolam 0.2 mg per kg IM. But now it is a dengue season. Avoid giving midazolam IM, because you may be dealing with a dengue child with a febrile seizure or a dengue encephalitis. And whenever you have thrombocytopenia, you can have a hematoma developing there. Otherwise, that is also a preferred route. If you don't have, and you don't want to give IM and you have not got an IV, please use the per-rectal route. You can use diazepam or lorazepam per-rectally. Just take a feeding tube, insert into per rectum 5 centimeter, and give the drug per-rectally. It would be effective. If the patient is having diarrhea, if you have an intranasal midazolam, that can be used. And if not, you can even instill midazolam in the buccal area also. Buccal efficacy is less. So there are so many routes you can give the first line anti-epileptic. So there's no reason why we should not be giving an anti-epileptic. And if the patient is unconscious and you are referring, please do the head tilt chin lift maneuver. And if the patient is having a trauma, don't go for head tilt chin lift. Instead, try for a jaw thrust so that your spine is not getting injured. An unconscious patient, always secure the airway with an oropharyngeal airway, because once you put the oropharyngeal airway, the tongue will not obstruct the airway. And on top of that, when you keep oxygen, the oxygen will reach where it needs to reach. So that is important. So, and at the same time, when you have a patient with seizure, take a time to think why your child is seizing. Am I dealing with a meningitis? If it's meningitis and your travel time is more than 1 hour, meningitis is a medical emergency, please give the first dose of antibiotic. If its travel time is less than 1 hour, you can definitely refer the child without an antibiotic. Always look at the pupils. If you find that there is an asymmetric pupil, you are dealing with a raised ICP patient. By the time the patient reaches the next hospital, he may already go for a brainstem herniation. So please give, if the BP is maintained, give mannitol 2.5 ml per kg. If BP is not maintained, give 3% saline 5 ml per kg and refer. Please look for other injuries, look for signs of shock. If there is shock, please start an IV fluid. And if you think that the seizure is as part of an intoxication, no fever, nothing, just coming with seizure, you can always think of giving an activated charcoal 0.5 gram per kg. Or if the seizure is happening and you're suspecting a poisoning, please do not use phenytoin. Please do not use sodium valproate, because they are sodium channel blockers. And many of the intoxicating agents, especially your tricyclic antidepressants, they are also sodium channel blockers and they may aggravate. So go for levetiracetam. If you're using a second line drug, that would be preferred. So what all we could have done for our child? We could have given a suction, we could have started an oxygen, we could have corrected the hypoglycemia, we could have started a fluid and prevented a hypotension. We could have given the first line anti-epileptic and then refer. I wouldn't say that if you had done all this, the child would have survived 100%, because say it is a fulminant encephalitis and the child would have coned otherwise also. But there were so many other things we could have done for this child. That's the only message. It doesn't mean that every child we can save, but it only means that we can definitely stabilize better a child with a neurological problem. Now, coming to the next case, was a 5-month-old baby who was admitted in the ward for sepsis, has been receiving cefotaxime for the last 2 days. But today, when the baby received the cefotaxime, the baby suddenly collapsed. Extremities cold, CFT 4 seconds with a heart rate of 166 per minute. Now, what do you want to do? The patients are all agitated. They say that you have given some drug, that means you have used a wrong drug and that is why the patient has collapsed. So immediately arrange an ambulance and refer, or try to wake up the child, or look for rash and urticaria and decide whether this is an anaphylaxis or not, or give adrenaline or keep the baby under observation. Now, this is the classical scenario of an anaphylaxis. Always remember, anaphylaxis happens if it is an IgE mediated anaphylaxis. It will happen only if you have been previously exposed to the drug. So don't anticipate an anaphylaxis when the first time you're giving an antibiotic. It can happen to the same antibiotic the patient was receiving for the last 2 days. Last time, the last anaphylaxis we had was for a child who had the anaphylaxis to the last dose of the antibiotic he was receiving. He was to be discharged that day. On the 5th day, you are discharging the child, the last dose of antibiotic goes in for an anaphylaxis. So this is something that we need to remember. So always remember, doing a skin test does not prevent an anaphylaxis, and routine skin testing is in fact not recommended. It only delays. Unless the patient has a history of anaphylaxis, it doesn't make sense. Because even when you have a skin test negative, you can still develop an anaphylaxis. Just imagine, this baby was already receiving antibiotic for the last 2 days, and today the baby has developed an anaphylaxis. And how do you know that the patient is not having a syncopal attack? Because any patient who falls after an injection, it can be due to the pain. During vaccination drives, we see that very commonly. A syncopal attack, that means when the patient falls down, the patient immediately, the sensorium improves after that. The central pulses are strong. Extremities may be slightly cold, there may be some sweating, but central pulses are strong, and usually it is a bradycardia. Whereas in anaphylaxis, even when the patient collapses and falls down, the tachycardia persists, the pulse volume doesn't improve, the situation only progressively worsens and not improve. So what do you do when you suspect? And remember, skin rash is not mandatory to diagnose anaphylaxis. A skin rash without a BP fall is only urticaria. And anaphylaxis, the BP fall can happen in the absence of skin rash, can happen in the absence of bronchospasm also. So that is also something that we need to remember. So once it is it is an anaphylaxis, immediately put the baby down, lift the leg so that the venous return is improved. And the drug of choice is always adrenaline. Please don't go after hydrocortisone. That is going to act only after 6 hours. You want to have this baby alive now. So give adrenaline 0.01 ml per kg IM. Maybe repeated every 5 minutes. If the patient is not improving, do not forget to start oxygen. And also, if the hypertension is not corrected, you can always give a normal saline bolus. Now, I said the dose of adrenaline is 0.01 ml per kg. A baby who has collapsed, you may not know the weight and you may be all panicky. Then you can just use a blanket dose. You have an infant, use 0.05 ml. You have a child, a 6-year-old, give 0.1 ml. 6 to 12 years, give 0.2 ml. For someone, and adolescent, give 0.3 ml, and adult, give 0.5 ml. Always remember, adrenaline is IM. This patient is in the ward. You also have a cannula there. Can you give IV? No. Because the heart is still breathing, is still beating. At that time, if you push such a large dose of adrenaline IM, he may go in for an arrhythmia. So IV push adrenaline is given only in arrest situation. And other situations when we give adrenaline, it is always an infusion. So always remember, for anaphylaxis, the drug of choice is adrenaline. And that is the drug that need to be repeated. And again, also telling, if you refer this child, the child will 99% die on the way. And this is applicable to any anaphylaxis happening anywhere. You have an anaphylaxis happening in your immunization clinic. The adrenaline should be given then and there. You should not try to lift the child, bring up to the ICU and give the adrenaline, because that's precious time. And many of times you will lose the child. So this is something that we need to remember. If you suspect an adrenaline, if you suspect an anaphylaxis, the treatment has to be given then and there and only then referred. Never refer without giving an adrenaline. Now coming to the last case, a 7-year-old child presenting with abdominal pain and vomiting. And now you can see the saturation is 90% in the room air, pulse rate 128 per minute, is on oxygen prongs. The saturation has improved to 95%. Can I refer this child? If you want to see this child, this is how the child needs. Chest is clear, no added sounds. What is the problem here? Look again. This is a child who's been brought in the middle of the night, 2 a.m. The history is she just got up from the sleep. She vomited once and then she complained of abdominal pain, and then they have brought the child here. But if you look carefully, what do you see? You see a baby who is lifting her eyebrows. Why should a baby lift her eyebrows? If she's sleeping, she will sleep. If she's awake, she will be awake. Why is she lifting her eyebrows? She's trying to open her eyes. That keep her eyes open, which she's finding it difficult. That is why she's using her eyebrows to keep her eyes open. That is a ptosis. Look at what is happening to the lips. You're asking her something, she's not able to say. She's trying to verbalize. That is a dysarthria that is happening. So this is a neurotoxic envenomation that is happening. And that is a descending paralysis. The ptosis has set in. The inability to speak has happened. You wait for some more time. The patient will go in for a respiratory failure, respiratory arrest. If you refer this child with an oxygen prongs, 99.9% you will receive the child in cardiac arrest. Please remember, children are more sensitive than adults. Adults, maybe they can reach a next hospital even after you have identified a ptosis. A child will never reach a next hospital once the ptosis has set in, because the venom injected by the snake is the same, whether it is a baby or whether it is an adult. And once the paralysis sets in children, usually it is very, very rapid. So this is so whenever you find a patient is hypoxic, so why is the patient hypoxic? 90%. Chest is clear and the patient is hypoventilating. Always remember, a respiratory distress you will identify. But someone is breathing less. How do you identify? It looks normal only. But when you find that the saturation is falling, then you should have a reason. If my patient saturation is less than 95%, I should say my patient is having wheeze. My patient is having pneumonia. My patient is having aspiration, conditions where the oxygenation is problem. If I find the chest is completely clear, then why is my patient having a saturation of 90? That is because he is breathing less. So the solution here is not that oxygen prongs. The solution here is support breathing. Start your bag and mask ventilation, intubate the child and refer. You're not able to intubate, start and put an LMA, bag and mask and refer. You don't have an LMA, just ambu and refer. The patient will come home, come to the next hospital alive and will go back home completely normal. But if you refer the child with nasal prongs, you will receive the child in arrest. Last time we had a small baby. In fact, they had seen the crate in the hand. Again, in the middle of the night, the baby woke up crying. The mother saw the crate on the hand, very small baby, just 8-month-old, taken to the nearest hospital. And the referring doctor has written neurotoxic envenomation, a saturation again 89%, started on oxygen mask, and then referred the patient in the ambulance with a male nurse with the ambu in hand, and it is written to give ambu SOS. Now, what is wrong with that prescription? The wrong with the prescription is that the patient, when the patient is presenting to you at 89%, that is the time to start ambu. Because the hypoxia is because the baby has already hypoventilating. So you don't have to hear what will happen when you keep an oxygen. The oxygenation will be maintained for a long time because of the extra oxygen that you're giving. But because the patient is not breathing, the carbon dioxide builds up. As the carbon dioxide goes on building, and finally when the saturation tries to fall, he will just go in for a cardiac arrest. So it's extremely important. A hypoxic patient, always you have to support ventilation and not oxygenation. So this was another child brought to a hospital with a history of unknown bite. You have examined the child, you did not find anything, no local reaction. Child walked into the hospital. But because they didn't have, they wanted the baby to be observed, they just referred the child. But we received the child brought dead to the casualty. Now, what can you do? The whole blood clotting time was checked from the referring hospital. It was less than 20 minutes. There was no local signs. So how do you refer such a child? This is important for you to know that even when there are no local signs and you're referring the child can develop a neurological symptom on the way. The child can go into a respiratory failure and cardiac arrest on the way, especially when the travel time is long. So how do you safely refer a child when you don't have any signs? I already said if the patient is hypoventilating, hypoxia, please start your bag and mask. If none of this is there and you're referring the child, then what do you tell the parents? You tell the parents that on the way, don't give anything by mouth because there's always a chance of vomiting and aspiration. Number two, keep the baby awake. Old times, they would say, don't allow the baby to sleep or don't allow to sleep anyone who has a snake bite. Because those days, they didn't know about neurotoxic bait, but they always knew that after a bite, if someone develops a drowsiness, if the eyes are closing, the patient will die. The same thing applies here also. So keep the child awake and talk to the patient. So you know the patient is awake and interacting, there's nothing wrong. If on the way, the patient becomes drowsy, if on the way, the patient stops talking, then you should not wait to reach the tertiary hospital. Instead, go to the hospital on the way, secure the airway, and then only travel fast. Because this particular child, in fact, when you elicited the history, he had stopped breathing by the time they had reached Karakutam. That means there's another half an hour for that baby to reach our hospital. And there are so many hospitals at that place where they could have easily entered and stabilized the airway and then travel journey, then continued the journey. But unfortunately, they just thought that they will reach the medical college as fast as possible. And we received the baby in death, brought death to the casualty, not even in cardiac arrest. We could not revive the child. So it's very important. So on the way, if there is a breathing problem, and then another thing, if you are suspecting a snake bite, I would say don't keep that oxygen and refer. Because the best method you can identify a hypoventilation is the moment the saturation falls below 95, you know that the patient is hypoventilating. Yes, start a bag and mask and secure the airway. Because as I already said, in snake bite, you need to support breathing and not oxygenation. For that, bag and mask is needed. So hypoxia here requires bag and mask and not simple oxygen mask. So again, repeating, whenever you have a hypoxia after a bite, it may be a snake bite, it may be a scorpion bite, look at the work of breathing. If there is an increased work of breathing, you're probably dealing with a scorpion bite, a pulmonary edema. You can do appropriate management for that. There you can definitely keep oxygen. There is no need to intubate and give prazosin. But in Kerala, we don't have venomous scorpion bite. So we do encounter scorpion, but they're never symptomatic. Whereas if you have a patient with an unknown bite, there is no increased work of breathing, but there is hypoxia. Please understand that is hypoventilation, and that requires a support of breathing by bag and mask, followed by intubation or LM. So finally, I have only one message. In the world of medicine, every case is a lesson and every patient is a teacher. May we learn our lessons and bring back the smile for more children. Thank you.
Thank you very much, dear Professor Dr. Sheeja Sugunan. Actually, it was a grand academic feast for every doctor. You described everything in a simpler way so that everyone could understand. It was an excellent academic journey. Thank you. Thank you very much. There are no words to describe your presentation. Thank you very much. And I'm sure everyone here will join me in my comments. There are very few doubts. The presentation, the entire talk is there in the IMA Kerala official YouTube channel so that you can view it again. So there's no problem with getting slides also. And then there are few questions which are there in my my chat box too. Before that, is there a confusion regarding adrenaline IV infusion or IM, ma'am? Could you just clarify?
Adrenaline is always IM. So imagine you have given 3 doses of IM adrenaline, and then the BP is still on the lower side. Then we start infusion and refer. So immediate management is always IM, only after 2 to 3 doses, because what we have to understand is that when you're giving IM, you're giving 0.01 ml per kg. So that's a bigger dose. When you're starting an infusion, you're just starting at 0.1 to 0.2 microgram per kg per minute. So it's always IM and always 0.01 ml per kg.
And so, as I said, this is the time for interaction. You can unmute and ask. Is there a book to read on general practitioners level? Let me answer at this a very, we are working on a handbook for every general practitioner. Not only the pediatric component, every component would be there. But meanwhile, let me let our Dr. Sheeja answer that question. Is there a book for pediatrics particularly?
I think Santosh sir's book is there. We can read that.
Yes. Can D5 be given instead of D10?
And I think, and we had earlier done an emergency care session for casualty medical officers. That book is also there. If anybody wants that MK's book, that is in immediate management, if someone wants, I can share the PDF. Definitely, you can have a look.
Ma'am, please share the image of those textbooks if you are available. We will publish it in our CGP, WhatsApp channel so that everyone will get. Then we'll be sharing the image of the those books which we have referred in the IMA CGP WhatsApp channel. The link will be shared again here, and please bear with us. And meanwhile, there is another question: can D5 5% dextrose be given instead of 10% dextrose?
Yes, D5 can also be given, but then you would require a huge quantity. If it's D10, you can give 2 to 5 ml per kg. If you're using D5, then you would require 5 to 10 ml per kg. Can be given, but D10 would be more better.
And there were some comments about DNS too. Or, DNS is hypertonic, right? So will it be useful? That is a question.
DNS for resuscitation or for maintenance? For maintenance, we can use DNS. For resuscitation, we will not use DNS because it contains dextrose. So it will cause hyperglycemia, and hyperglycemia will cause glucosuria, and glucosuria, in fact, will increase the urine output and make your shock correction delayed. And hyperglycemia has many other side effects. So resuscitation fluid should never be DNS. Maintenance can always be DNS.
There is a general practitioner asking a very frank question. See, when we see kids, though we are forced to see all kind of patients, when we see the kids, quite often they think that will they err, so they refer fast. Your comments.
No, I can't. No, see, we have all gone through that journey, right? As a house surgeon, I still remember when we see the last baby, that you don't want to see babies at all, especially infants. So that is quite common because pediatrics, they don't verbalize and tell you what is wrong with them. But as I said, if you go systematically, it's very less chance that will go wrong. Just follow that algorithm, A, B, C, D, E, and that 5 triage questions. Don't worry, you will not go wrong. The triage questions itself will give you most of the 90% of the sick patients you can get from the history. Only 10% you would require an examination.
To add a note on that, kindly do mock drills. Whenever you get time, you can interact with your seniors or you do mock drill, because the checklist will work when you do mock drill. And ma'am, in anaphylactic shock with poor peripheral circulation and muscle perfusion, is there an IV line in place? Should we still try IM or give the appropriate dilute IV bolus?
Okay, I think that's a very good question. Basically, in anaphylactic shock, why we don't give subcutaneous is exactly the reason what you said. Because naturally, the peripheral perfusion is less. So, skin perfusion is less, muscle perfusion is maintained for a longer time. So, if you give something subcutaneous, it will take half an hour. If you give some muscle, it will act earlier. But for a beating heart, you will never give an IV adrenaline push. Because as I already said, the adrenaline that we are using as for anaphylaxis is a larger dose. So that cannot be given as an IV push. That has to be given IM. And after IM is not responding, you can always start an adrenaline infusion. Infusion dose is different from the IM push. So prefer to give IM push itself.
There is another question in the personal chat box. Shall we do bag and mask with oxygen or simply bag and mask?
Okay, if your patient is hypoxic, it's always bag and mask with oxygen. But this situation, if for example, I said you have taken a snake bite child, they was otherwise okay and suddenly becomes hypoxic. Even if you do a roam air bag and mask, the saturation would pick up. So any hypoxic child, you usually start with oxygen and then try to wean off oxygen. But otherwise, if the lung is normal, even a room air bag and mask will bring up the saturation.
Now, I welcome Dr. P.S. Sharma, who has raised the hand. Sir, do you have any comment to share?
I think we need to unmute maybe.
Maybe. Right. Now we have our Dr. T. Suresh Kumar, sir, the former state secretary and a renowned pediatrician here with us. Sir, would you like to share any comments? Suresh, sir? Friends, it's time for us. It was indeed a great academic feast. IMA CGP will be with you in empowering you by any means, like, in your profession, in your organization, in your welfare, in your enlightenment, every means, IMA is with you. Friends, there is ma'am, there's another question. Can you repeat the site of retraction-based diagnosis? Physiological assessment.
Okay, basically, when you're looking at the child, if you have a suprasternal or sternal retraction, it usually indicates it is an upper airway obstruction. You have upper airway. So, for example, a very bad wheezer can also have a suprasternal retraction, but commonly at the onset itself, you have a suprasternal and a sternal retraction. Commonly, the commonest cause would be either a foreign body or a laryngotracheobronchitis. If you have subcostal retractions, it may be a little difficult to make out a subcostal and an intercostal, but usually subcostal retractions, especially with a prolonged expiration, indicates a lower airway obstruction or asthma. So either the expiration is prolonged, or if you see that they're using the shoulders to expire, that basically means you're dealing with an asthmatic child. It is a airway obstruction. Whereas if you have a grunt, that is every breath the baby makes a sound, that's a danger sign that usually indicates a lung parenchymal disease. And it is usually associated with lower chest indrawing. It's like an intercostal indrawing, but the lower chest goes in when the baby is taking a breath.
During our routine immunization, after giving rotaviral vaccine, baby developed erythema on both lower limb, checked vitals, all were normal. Can it be due to the vaccine?
Sorry, I didn't get the question.
No worries. During our routine immunization, after giving a rotaviral vaccine, baby developed erythema on both lower limb. Checked vitals, all were normal. Can it be due to vaccine?
So if it is developing within 4 hours of the vaccine, it can still be an allergic reaction to the vaccine. As such, rotaviral vaccine causing an allergy is extremely rare, but anything anybody can develop. And the usual time is, most of them will develop within 20 minutes, but oral things you can have up to 4 hours for developing a rash. It is possible. You cannot say it is not due to that.
How to start adrenaline infusion in peripheral hospital?
Okay, that is a very good question to be asked. Basically, commonly the rule of 6 is what we follow. That is 0.3 mg per kg of adrenaline is taken in 50 ml of normal saline, and we start at 1 ml per hour. That is commonly that is what we do.
Excellent. Thank you once again, Professor Dr. Sheeja Sugunan. It was indeed, as I said, it was indeed a great academic feast. We are grateful to all the participants, all the delegates who have attended this program across India, and also those who were watching in the YouTube channel too. There were a lot of live watchers. Thank you all. Friends, we will meet in the next Thursday at 8 p.m. with a grand discussion on acute abdomen by Professor Dr. Dayananda Babu, Professor Emeritus of Gogula Medical College. Friends, please do join us. Please do follow our IMA CGP WhatsApp channel, and we'll be there with you, empowering in every day's medical practice. Thank you once again. Thanks a lot, dear madam. We are proud that we have you as our professor and chief intensivist at SAT Hospital. And SAT has always led a great, path in the academic array of pediatrics. Thank you very much. Keep going. We are all with you. Indian Medical Association, IMA Kerala CGP. Thank you.
Thanks.
Thanks, everyone. Thank you. Good night.